Research title: Outcomes of conjunctival flap surgery in patients with refractory fungal keratitis. I will discuss in detail the information you can get about this research, so please watch this video carefully to learn about my research. Let's get started. First, I will talk about the introduction of this research. Introduction: Fungal keratitis, FK, is a serious, ulcerative, and vision-threatening corneal infection first described by Labor in 1879. Labor, 1879. Compared to bacterial keratitis, FK often has a poor prognosis, with nearly 50% of patients in developing countries requiring surgical intervention. Gopinathan et al., 2009. Early diagnosis and treatment are essential to prevent long-term vision loss. Tina et al., 2019. FK is more common in men, usually following plant-related eye trauma. Cater et al., 2014. Topical antifungal drugs are often fungistatic and may fail, making surgical options necessary when medical therapy is ineffective. Kaur et al., 2008, Abad et al., 1996. Conjunctival flap surgery is a simple, effective, and affordable procedure for refractory FK, especially in developing countries where donor corneas for keratoplasty are limited. Garg et al., 2018. It stabilizes the ocular surface, prevents ulcer progression, reduces pain, and can serve as a temporary measure before future corneal transplantation. Techniques like the Gunderson flap and selective partial pedunculated flaps have proven effective while minimizing complications. Gunderson, 1958. Globally, refractory FK is increasing, but local data on conjunctival flap outcomes are limited. This study was designed to evaluate the clinical outcomes of conjunctival flap surgery in patients with refractory fungal keratitis. Next, I will explain the rationale behind this research. Rationale of the study: fungal keratitis, FK, is a major cause of ocular morbidity worldwide, with increasing prevalence of refractory cases, especially in developing countries. Men are more commonly affected, often due to plant-related trauma. FK has a poorer prognosis than bacterial keratitis and often responds poorly to topical antifungals. Therapeutic keratoplasty is frequently required, making management challenging. Although several international studies have evaluated conjunctival flap surgery for refractory FK, no data are available from Bangladesh. This study aims to assess the clinical outcomes of conjunctival flap surgery at a tertiary hospital, NIONH, providing potential benefits to patients and guidance for ophthalmologists in treatment selection. Next, I will explain the hypothesis behind this research. Hypothesis: Conjunctival flap surgery enhance the healing process in refractory fungal corneal ulcer. Next, I will explain the objective behind this research. Objectives: General objective: to assess the effectiveness of conjunctival flap surgery in refractory fungal keratitis. Specific objectives: to assess the relief of pain in pain scale, to observe the reduction of hypopyon with slit lamp biomicroscope, to assess the ciliary congestion, to observe complications after conjunctival flap surgery in refractory fungal keratitis. A. Flap retraction. B. Corneal perforations. C. Flap necrosis. D. Others, such as flap displacement, endophthalmitis. Next, I will explain review of literature behind this research. Review of literature. Fungal keratitis, FK. Infection of cornea by fungi. First described by Labor, 1879. Epidemiology. More common in tropical regions. Men aged 21 to 50 at higher risk. Plant trauma frequent cause. Pathophysiology. Fungi invade corneal stroma through epithelial defects, produce enzymes and toxins, may cause perforation. Risk factors: corneal trauma, topical steroids, diabetes. Diagnosis: clinical signs, slit lamp, co-mount, culture, gold standard, confocal microscopy, PCR. Conjunctival flap surgery. Reversible, vascularized flap. Stabilizes ocular surface, reduces pain, promotes healing. Techniques: Gunderson flap, tongue-shaped partial flap. Previous studies: successful globe preservation in refractory FK. High anatomical cure rate, 88–94%. Complications: pseudopterygium, cataract, corneal opacity, rare perforation. Can serve as temporizing measure before keratoplasty. Next, I will explain the methodology behind this research. Methodology: study design, prospective observational study. Place: Department of Cornea, NIONH, Dhaka. Period: October 2021 to September 2023. Population: patients with refractory fungal keratitis. Sample size: 50 patients, purposive sampling. Inclusion: FK greater than 2 weeks of treatment. Exclusion: other keratitis, neurotrophic, neuroparalytic cornea, bullous keratopathy. Independent variables: age, sex, occupation, disease duration, laterality, visual acuity, epithelial defect size. Dependent variables: pain, hypopyon, ciliary congestion, post-op complications. Operational definitions: refractory FK, no improvement after 2 weeks of intensive treatment. Pain, VAS 0 to 10 scale. Procedure: history, demographics, ocular exam, VAS pain scoring. Conjunctival flap surgery, modified Gunderson, under peribulbar anesthesia. Flap sutured over ulcer, post-op antibiotics and bandage. Follow-up: day 1, day 7, 1 month, 3 months, pain and anterior segment evaluation. Data analysis: SPSS 26.0, percentages, tables, figures. Ethics: Helsinki Declaration followed, informed consent and confidentiality maintained. Next, I will explain results behind this research. Results: Table I. Age distribution 60 years, 27, 54%, 51 to 60 years. 19, 38%, 41 to 50 years. 4, 8%. Mean age, 62.82 plus or minus 12.38 years. Figure 1. Sex distribution. Male, 34, 68%. Female, 16, 32%. Table 2. Occupational status. Farmer, 19, 38%. Housewife, 13, 26%. Day laborer, 9, 18%. Service, 6, 12%. Others, 3, 6%. Table 3. Laterality of eye. Right, 29, 58%. Left, 21, 42%. Table IV. Duration of disease, 21 to 25 days. 32, 64%. 25 days. 18, 36%. Mean, 24.68 plus or minus 2.78 days. Table V. Visual acuity. 11, 22%. Place, 22, 44%. CF, 30 centimeters. 11, 22%. 6, 60 to 6, 12%. Table V. Epithelial defect size is less than or equal to 3 mm. 17, 34%. 3 mm. 3, 66%. Mean, 3.62 plus or minus 1.36 mm. Figure 2 and Table 7. Pain, VAS, pre-op, 4.1 plus or minus 1.75 right pointing arrow 3 months. 0.39 plus or minus 0.09. Significant reduction over follow-ups. P less than 0.05, Table 8 and X. Hypopyon status 1 to 2 mm. 26, 52%. 2 mm. 24, 48%. Mean, 2.22 plus or minus 0.84 mm. Follow-up reduced to 1.00 mm at 1 to 3 months. P less than 0.05. Figure 4. Ciliary congestion. No congestion, 94%. Present, 6% at 3 months. Figure 5 and Table X. Complications. No complication, 46, 92%. Retraction, 2, 4%. Flap necrosis, 1, 2%. Corneal perforation, 1, 2%. Next, I will explain discussion behind this research. Discussion. Fungal keratitis often requires surgical intervention due to poor response to medical therapy. Conjunctival flap surgery is effective in restoring corneal integrity for unresponsive cases. Age and sex. Majority greater than 60 years, 54%. Mean age 62.82 plus or minus 12.38 years. 68% male, 32% female. Findings consistent with previous studies, Gopinathan et al., 2009, Yao et al., 2017. Occupation. Farmers 38%, housewives 26%, day laborers 18%. Consistent with prior studies showing agricultural workers at higher risk. Duration of disease. Mean 24 plus or minus 2.78 days, majority 21 to 25 days. Aligns with earlier studies, Yao et al. 2017, Tran et al. 2023. Pain, VAS. Pre-op 4.1 right pointing arrow 3 months 0.39, showing significant pain reduction after surgery. Comparable with Yao et al. 2017, Nizeyamana et al. 2017. Hypopion. 100% had hypopion pre-op. Reduced to 1.00 mm at 1 to 3 months post-op. Surgery highly effective, p less than 0.05. Ciliary congestion. Present in 100% pre-op. Reduced to 6% at 3 months. Complications. 92% had no complications, 8% had minor issues, retraction 4%, flap necrosis 2%, corneal perforation 2%. Findings consistent with previous studies, Zhang et al. 2018, Alino et al. 1998. Proper debridement minimized complications compared to some prior studies. Conclusion. Conjunctival flap surgery is safe and effective for refractory fungal keratitis, providing pain relief, reducing hypopion, and preserving ocular integrity with minimal complications. Next, I will explain limitation behind this research. 6.2 Limitation. Sample size was small and thus results cannot be generalized on the basis of this study. Culture and sensitivity and other tests was not possible due to lack of availability. Long-term follow-up was not possible. Single center. Next, I will explain recommendation behind this research. Recommendation. To make more conclusive result, a multi-center study with a large number of patients with long-term follow-up can be done to assess the effective clinical outcome of conjunctival flap surgery. A conjunctival flap surgery may be considered by ophthalmologists in refractory fungal keratitis to overcome the complications due to poor response to medical therapy. This concludes today's session. Thank you for joining and engaging with us. I didn't include online references in this limitation, but if you want any, just hit that subscribe button and drop your request in the comments below.